I'm Ann Partridge from the Dana-Farber Cancer Institute, and I'll be speaking about tolerability and other practical issues in ovarian function suppression, including the potential utility in preserving fertility. The first case is a 35-year-old woman who presents with a left breast mass. The mass is 3 centimeters, and an ultrasound confirms a 3.5 centimeter mass and an enlarged axillary node. Her mammogram, unsurprisingly, given she's only 35, reveals dense breasts, and an MRI confirms a left breast mass in the upper outer breast, and there are no additional findings beyond the enlarged lymph node. A core needle biopsy shows high-grade triple-negative invasive breast cancer, ductal carcinoma, and a biopsy is consistent with breast primary. She undergoes rapid genetic testing and has a pathogenic variant in BRCA2. She does have some family history. She's a lawyer, she's married, and she just started to try to get pregnant when she had palpated that mass. What would you offer her next? How do we think about this from a surgical standpoint? What are the preoperative treatment options for a patient like this? This is, of course, what we think about in our multidisciplinary clinic. But the other major issue for many of our young patients, nearing 50%, is how about fertility? And does she need fertility preservation? If so, what? And how do we think about future pregnancy considerations in this patient? And of course, like for any patient, we think about future surveillance and risk reduction recommendations when we're caring for someone like this. So the patient is recommended to receive preoperative Keynote 522 regimen. She chooses to undergo 1 cycle of IVF before starting treatment, which she does over a 3-week period, and there's reasonable safety data to support that. Fortunately, she banks 10 embryos and 8 oocytes, which is a pretty high yield from IVF in a patient who's not infertile yet, and she plans to consider pre-implantation genetic diagnosis in the future. That's trying to select out the embryos that don't or do have the BRCA mutation. During treatment, she also opts to receive leuprolide so that she can try to prevent premature menopause and potentially additionally preserve her fertility beyond what she's done with regard to banking eggs and embryos. She tolerates chemotherapy quite well with an excellent clinical response. The mass shrinks, the lymph node shrinks. When she goes on to surgery, her nodes are negative, and there's some evidence of treatment effect in the node, in the clip node, and she has only 3 millimeters of residual grade 2 invasive ductal carcinoma. It's also triple negative. So she sees you in follow-up. It's about 3 months into her adjuvant pembrolizumab, which of course is part of the Keynote 522 regimen. She plans on completing the full 14 additional weeks, and she wants to know, when can she get pregnant? And then, of course, she's a BRCA mutation carrier, so when should she get her ovaries out? She's 35 years old, and she has questions about her overall treatment, whether it's worked, and how we're going to follow her, which, of course, is not the focus of this discussion, but we can talk about that if we'd like, especially in the context of someone getting pregnant potentially. So in order to address her issues, you first have to go back and say, well, what works to prevent infertility after breast cancer? And we know that age and treatment regimen are some of the biggest predictors of risk of amenorrhea and infertility after breast cancer. This woman is 35, so she's already starting on that slope of risk of becoming infertile just by age alone. And she has a large triple negative node positive breast cancer, so she needs pretty aggressive therapy. So we're not going to hold off on therapy, and she's in a situation where she is at high risk of becoming infertile. So it's great that they sent her in for fertility evaluation with reproductive endocrinology. And then the other big thing we think about is suppressing her ovaries through treatment. These are data on this slide from a large meta-analysis, which was done with the available randomized trials using GnRH agonists through treatment in women who were at risk for premature menopause and infertility after a breast cancer diagnosis. What this showed was that those who got the GnRH agonists had about half the rate of premature ovarian insufficiency compared to women who did not get that through predominantly alkylating agent chemotherapy, multi-agent chemotherapy. In addition, the meta-analysis demonstrated that women who got GnRH agonists through treatment also had a higher likelihood of having a baby after breast cancer. But it's really important to consider the fact that the numbers are pretty small in the baby groups. And while there was a doubling of pregnancies in those who used the agonist compared to those who didn't, it was only 37 pregnancies in the group that used the intervention and 20 who didn't. And all of those pregnancies were in women under 40. It's not so clear whether any of the women over 40 were trying, but that being said, we need to be careful about what we offer people in terms of promises with regard to this therapy. And it's something that we do through treatment, but we also say don't do it instead of other more standard recommendations for preservation of fertility, like banking eggs or embryos, or the more research area of banking ovarian tissue, if that's something to consider. We do this as kind of an adjunct, or if you can't bank eggs or embryos. So good news is that the studies that have been done, as well as the meta-analysis, also suggested that there is no clear worsening of disease-free or overall survival from the breast cancer in people getting GnRH agonists through chemotherapy. So we do reach for it, but we have to be careful not to overpromise. And then most recently, the data from the PROMISE GIM-6 study, the long-term outcomes, where they're now going out 9 to 10 years plus, have shown that this has held up over time, that there does appear to be safety in terms of using a GnRH agonist through treatment in terms of the breast cancer outcomes. And there were 80% of these patients had ER-positive breast cancer. So getting a GnRH agonist through treatment did not worsen people's outcomes from a breast cancer standpoint. And, the efficacy data I showed you earlier, patients were more likely in general to preserve ovarian function and have a baby after breast cancer.
So a couple of questions. First, would this ever be a consideration just in a woman just to preserve ovarian function? A 30-year-old, 35-year-old woman who really isn't planning to get pregnant, but would like to avoid premature menopause. Is that anything you ever think about or even do?
We absolutely think with patients about preserving their ovarian function for other reasons beyond just preserving fertility. Many women, especially women with hormone receptor negative breast cancer, where we're not suppressing ovaries in an effort to treat the cancer because we don't think that would be helpful, what we definitely would want them in general to have their ovarian function, because we know that's better for their, sexual lives, for their bones, for their hearts, for their brains, potentially in the long term, and other potential comorbidities down the line. And so using an ovarian function suppression agent through treatment may also help them in the long run. My strong suspicion is that that is woefully underutilized in both academic and community practices, because we tend to reach for the GnRH agonists as kind of a go-to when we're thinking about fertility. We think much less about it when we're thinking about just preservation of function because we want to. And I do think that that's something we need to probably be more aware of and bring up with our young patients who are done with babies but still might want ovarian function for good reason, and we should preserve it with them.
Also, I'm kind of curious whether quality of life is impacted. You're already giving them chemotherapy. Do you see, I don't know if you can figure out whether it's worse quality of life by adding in ovarian suppression because the chemo's on board, it's maybe not that much of an issue.
What's really interesting is that during chemotherapy, when we give people ovarian function suppression, anecdotally, it does seem like they're more likely to have hot flashes and some more symptoms. When they looked in a exploratory analysis in the TEXT trial, where patients got ovarian function suppression during chemotherapy, if they got chemotherapy, and then some of them got it without chemotherapy, the patients, and I'll show you the slide later, the patients who got chemotherapy complained generally less in patient-reported outcomes about the toxicities of the hormonal therapy. They had fewer symptoms in general related to the hormonal therapy. And that, that kind of is probably because, they've been through chemo, and the chemo side effects so outweigh the hormonal therapy side effects for most women, at least in the short term.
Please continue.
So let's switch to another case. And this is a 32-year-old woman who sees you for a second opinion. She was diagnosed 18 months ago with a high-grade hormone receptor positive breast cancer. It's HER2 positive as well. It was clinically T2, about 2.5 centimeters, and clinically node negative. She received neoadjuvant paclitaxel, trastuzumab, and pertuzumab on a clinical trial, and she had a PCR. On this trial, she got to forego the additional chemotherapy and just take HP, and she starts tamoxifen and ovarian function suppression during the HP therapy. She wants to know the optimal duration of hormonal therapy and when she can become pregnant. And obviously, this is a different situation than someone who doesn't need to take hormonal therapy, because we know that hormonal therapy is something we give to our young patients and old patients, older patients, for 5 to 10 years, depending on their level of risk, preferences, and tolerance. We know in breast cancer survivors, they have a lower pregnancy rate compared to other cancer survivors, and certainly compared to the general population. You can see here, breast cancer is only second to cervical cancer in terms of survivors having babies or pregnancies after the diagnosis of cancer at a young age. We also know that from a study done by Lambertini and colleagues, that pregnancy, delivery, and fetal outcomes are very similar in some settings, but appear to be worse in other settings with regard to the effects on both the pregnancy and the progeny. So we don't think that in a survivor, there's any great risk to the actual pregnancy. And women are able to complete their pregnancies. They're no more or less likely to have, from what we can tell, preeclampsia or deliver by C-section or have a peripartum complication as a survivor. But there does appear to be an increased risk of having low birth weight babies or preterm babies, and no clear increased risk for small for gestational age or congenital abnormalities. But the small for gestational age is borderline in terms of its significance in this study. So we do worry about the progeny to some degree in patients who have survived a breast cancer. And we need to do more work to look at that and make sure we're counseling people appropriately. The other big thing we worry about in survivors and their desire to have a baby is whether or not having a baby after breast cancer will impact on their breast cancer outcomes. So before we were talking about fertility and fertility preservation impacting their breast cancer outcomes. Here we're talking about those who become pregnant versus those who don't. And as you can see depicted in this slide from a large meta-analysis, there does not appear to be any worsening of outcomes. And in fact, they look a little bit better in people who go on to have a pregnancy compared to those who don't. Of course, we always worry in any observational study like this about something called the healthy mother bias, which is that women who go on to become pregnant are healthier and potentially more likely to be counseled by their physicians. They might be lower risk. They may be more likely to be sexually active and able to get pregnant if they're doing better after a breast cancer. You can see here, this also looks at that broken down by estrogen receptor status, hormone receptor positive on the left and hormone receptor negative on the right. And again, no clear signs of harm, even in a patient who has hormone receptor positive breast cancer history with regard to their breast cancer outcomes. The good news is that we recently presented the positive trial, which was designed for a patient just like the one in our case, which is essentially a study where premenopausal women desiring pregnancy who were 42 or younger and had taken at least 18 months of endocrine therapy and no more than 30 months. They had to have taken some endocrine therapy up to 2.5 years and have no evidence of clinical recurrence. They didn't have to be staged or anything. Those patients took a planned interruption of endocrine therapy in order to have a pregnancy. They were able to, if they could get pregnant, conceive, deliver, breastfeed if that was desired, and they were able to. And they also had to have a 3-month washout period to get their endocrine therapy out of their system. There were some pretty strict things built into the protocol. If they weren't pregnant by a year, they were strongly encouraged to have a fertility assessment, and they were allowed to use IVF and other fertility strategies from the reproductive technology colleagues. And about 43% of women did indeed use some form of assisted reproduction. Then they were strongly encouraged to get back on their endocrine therapy within a 2-year period and complete a total planned duration of 5 to 10 years, depending on their level of risk and preferences and tolerance in conjunction with their provider. And we're following these patients for long term. And the really good news that we presented at San Antonio in 2022 was that the breast cancer outcomes were below our predetermined safety threshold. So there were 44 events in terms of breast cancer-free interval events, and we had set a threshold at 46 based on prior studies. Half of those events were distant events, totaling about 22 events. We also had used a well-controlled analysis from the text and soft pool of patients who would have been eligible for the positive trial. And as you can see here, in those patients, when they are superimposed in terms of their breast cancer-free interval and distant recurrence-free interval, they did similarly to the positive patients. So there was no clear difference in breast cancer outcomes with this calculated historical control group compared to the positive breast cancer outcomes from taking a temporary interruption of endocrine therapy compared to the group that didn't take a temporary interruption from endocrine therapy. So these were very exciting data, and I think something that we can use in our practices to support our young patients to make decisions about potentially taking a break from endocrine therapy, to have a pregnancy, and then get back on and complete their endocrine therapy.
I just wanted to say that I've already quoted you several times, not just in breast cancer seminars, but other seminars. I loved what you said. I think it was at the end of the talk where you talked about the idea you want your patients not just to survive, but to thrive. I love that thought.
Thank you. Thank you. This is good stuff.
Please.
This is really good stuff.
But you know, the whole idea, I think people do focus so much on survival that sometimes they forget, you know, there's more to it than just surviving. So I thought it was really a great comment.
Thank you. Yeah, super important.
All right, please continue.
So we're planning to follow the patients in the positive trial for their long-term outcomes, which is super important, as you know, because ER-positive breast cancer has a long disease trajectory. And while we have very nice results, very positive results from the short-term outcomes, these are indeed only short-term outcomes. This is with a median follow-up of about 3 years, 5 years out from their diagnosis. And it's very encouraging, but we need to also follow these patients long-term. So now I have another case, a 25-year-old woman now who presents with a mass in her right breast. And she's diagnosed with stage 1, T1CN0, MZR, ER-PR positive, HER2 negative breast cancer. It's grade 3, which is not uncommon for our young patients. About 60-some% will have grade 3 disease, which is in contrast to our older patients who are more likely to have grade 1 and 2 disease. Her tumor is sent for Oncotype because she fits the criteria for sending Oncotype, and it's a score of 26 comes back. She gets 4 cycles of TC because that's above the threshold where we start to see some benefit from chemotherapy. And she sees you in follow-up for discussion of optimal hormonal therapy. She's actually feeling quite depressed and concerned about trying anything further at this time. She did just complete radiation therapy. She was very tired. This is actually someone I saw in my practice last week. The idea of doing anything else right now feels a little overwhelming for her. So we needed to come up with how can we get her hormonal therapy too, because we know that while we gave her chemotherapy and we hope that will give her some good risk reduction, and based on the evidence it should, hormonal therapy is still the most important risk reducing strategy systemically for people with hormone receptor positive breast cancer, even when they need chemotherapy. So, how do we decide about hormonal therapy in our young patients? And we know now from the SOFT trial that tamoxifen is good, but ovarian function suppression, in addition to tamoxifen, is better in terms of disease-free survival. And then if you use an aromatase inhibitor, exemestane plus ovarian function suppression, it's even better. And that was the data from the TEXT trial. But we also know that adding the additional therapies, of course, adds side effects. And here, I'm talking about this young 25-year-old who's in such a age normative situation where she's having hot flashes, she's miserable, she's tired. She's actually a newlywed, by the way. And so, how can we help to choose the best bang for the buck for her? She doesn't have 20 lymph nodes positive. I'm not super, worried she's going to recur tomorrow. And at the same time, I don't want to leave any risk reduction that's reasonable on the table when I'm thinking about, her risk reduction, nor does she or her family. So I tend to reach and think about the side effects with patients. And, we know that when you add ovarian function suppression, and that's why I included this graphic, you do add side effects. And the biggest side effects we see, as demonstrated in the SOFT initial results, and these are the investigator-reported side effects that are greater in patients who get ovarian function suppression, generally are hot flashes, and there's a slight increased risk of depression-type symptoms in general. And otherwise, things like insomnia can be more common, and musculoskeletal complaints are a little more common anecdotally, but not in the SOFT trial did we see that, as you can see. Osteoporosis is greater risk, but it's still quite low in young patients. And there's a slight increased risk, as you can see here, of glucose intolerance in the patients on this ovarian function suppression. There were more adverse events in the patients on ovarian function suppression. And this is grade 3 or 4 events that we're calculating here, but they were not common per se. All right, here are the patient-reported outcomes. So this is really important because we know that investigators, when we're using our typical CTCAE, patient complaints and then putting it into a chart or into a CRF, when you do research like this, we know that we underestimate what the patient experiences. I think this is the SOFT patient-reported outcomes where you can see clearly that patients are reporting a lot more hot flashes in the yellow bars, which is the tamoxifen plus ovarian function suppression. There's a lot more sweats in the patients getting ovarian function suppression. Otherwise, there's a lot more sleep disturbances, a bit more loss of sexual interest, and difficulty with libido, and difficulty with vaginal dryness as well. And you can see that those problems persist over time, although they do get a little better as people get further out. By 2 years, people tend to settle down, but they're still present even out the full 5 years of therapy. You can see here overall quality of life, however, when you measure it using a global quality of life measure, getting physical well-being, mood, coping, treatment burden, and health perception, the only thing that registers throughout the trajectory of treatment is treatment burden. Mood typically, at least across the board for all comers, and physical well-being is not particularly worse with ovarian function suppression added to tamoxifen. That doesn't mean that individual patients won't have a hard time and that we need to meet the patient where they are, like my young patient that I just described. But it's not so clear that it's always the addition of the hormonal therapy or the extra hormonal therapy with ovarian function suppression. Like I said, my young lady who's menstruating through treatment is already somewhat depressed and having trouble coping, as well as very tired after her chemo and radiation and surgery. here are the data from the TEXT trial, and I only include this to illustrate the fact that we have annotated and looked very carefully at our studies for the risks and what the different agents add. And, there are some differences with agents, but again, they do not impact on global quality of life across the board. There are, substantially greater numbers of hot flashes. And the biggest thing when you switch from an aromatase inhibitor from tamoxifen to an aromatase inhibitor from tamoxifen is really the effects on the bones, as well as a bit more vaginal dryness. But then some settings, there's a little more hot flashes with the tamoxifen, and that's what was borne out in the TEXT analysis.
I just want to ask you, do we know randomized trials compared ovarian suppression alone to tamoxifen ovarian suppression and to tamoxifen alone?
So no, we did not do that. There was an ECOG trial that Nancy Davidson led a while ago that was tamoxifen, and then there was ovarian suppression with chemotherapy. It was with tamoxifen, I think, but they never have done the opposite. There are older trials of CMF versus ovarian function suppression. In fact, I have that slide here, and they were equivalent. 2 to 3 years of ovarian function suppression was equivalent to CMF. But no, there hasn't been that study. And that's because the tamoxifen was shown to be better and more tolerable in general. So we all abandoned the ovarian function suppression for a long time.
Please continue.
So another big issue that comes up when we're thinking about treating our young patients with ovarian function suppression. And incidentally, for the case that we're talking about, the young woman who's 25 and tired, we decided to give her a little bit of time to recover, and we were going to start her on tamoxifen to add to her ovarian function suppression. So she was already on ovarian function suppression through the chemotherapy because she had wanted that for ovarian function preservation if possible. She didn't bank eggs or embryos because she was quite young, and we didn't think she would need it because she was only 25, and the likelihood of going into menopause or actually needing it at that age is quite low. Those patients tend to retain their ovarian function, as we and others have shown in other data previously. But she did want to take the ovarian function suppression through treatment because it was easy to do, and it was going to be part of her treatment regimen ultimately, although it may have been contributing to her fatigue. And so we continued that, and we added tamoxifen. So one of the big issues that comes up is how often should we give the GnRH agonist? And of course, for patients, it's much more convenient to get a drug every 3 months. And there's also the issue of which agent to use, because we can do it monthly or every 3 months, and there are options in terms of the agent to use. The SOFT trial, which of course was a research study, used triptorelin monthly at 3.75 milligrams, and the early breast cancer trials clinical trials group used only one of them used leuprolide in the studies that were considered, and the rest used triptorelin and goserelin. So, a lot of our data we use and extrapolate to whichever agent is on formulary at our institution. And we're going to go through a little bit of those data now. What you can see here is that they all can suppress estradiol, and it's pretty similarly effective regardless of which agent you're using. You can see here that in terms of dosing, here we are comparing a 3.75 milligram dose of leuprolide to 7.5 milligrams. They're all pretty effective dosing-wise in suppressing estradiol and estrone, as well as being associated with the commensurate increase in LH and or decrease in LH and increase in FSH that should occur when you are suppressing the pituitary axis. Here you can see the comparison of that with the leuprolide at the higher and lower dose as well, and how it goes down over time. Both seem to work. Here you can see it with goserelin over time. And you can see that Leuprolide monthly dosing was used in a large American cooperative group trial of tamoxifen plus versus tamoxifen plus ovarian function suppression, and there were no real differences in terms of this, but the study was stopped early and it was underpowered. Here you can see that whether ovaries are removed or they are radiated or an LHRH analog is used, there does not appear to be a difference in disease-free or overall survival, either adjusted or unadjusted, from prior research as well. So a lot of times we're asked, should we get the ovaries out? And if a patient is regularly using their ovarian function suppression and they appear to be suppressed clinically, then it doesn't seem that that makes a difference. There's more work going on in that, trying to tease that out in our very young patients, I'll tell you, because I'm starting to see some suggestion of potential differences, at least by hormone levels, but we're not sure it makes a difference in the long run in terms of their disease outcomes. How low is low enough is not so clear. Here you can see a comparison with using Leuprolide of monthly versus quarterly treatment at two different doses, obviously. And you can see that both suppress fairly rapidly and consistently. So many of us have moved, especially during the time of the pandemic, to offering treatment more frequently every 3 months for patients if that's more convenient and they're more able to get in and get it. Because as we know, drugs only work for people who take them. And between the pandemic and trying to help keep people out of the clinic and keep them safe, as well as people wanting to have the convenience of not having to come to the cancer center every month, if we think that the process outcome of suppression of ovaries is just as good with an every 3-month formulation, and some are even testing potentially even longer formulations. In prostate cancer, they're using some longer formulations. Wouldn't it be nice to bring that into the breast cancer world so our patients didn't need it that often? If they tolerate it just as well, it's nice to not have to come to the clinic as often. Again, here's some 3-month Leuprolide dosing data with regard to suppression of the estradiol and FSH. Here's a comparison of using Leuprolide every 3 months to CMF, and you can see that they equally suppressed the ovaries with that, how well the estradiol was suppressed with the Leuprolide. It's not as short-term effective, interestingly, as it can be with taking ovaries out, but it does get people to a better place and very low. Here's the Leuprolide for 2 or 3 years. Sometimes the E2 levels can wear off a bit and they recover. There have been direct comparisons of some of the GnRH agonists, and here's one study that compared goserelin to Leuprolide monthly versus quarterly, respectively, and there was no clear difference in terms of suppression of the estradiol levels, as you can see. Here is another study showing goserelin monthly versus quarterly alone, and again, no clear difference. They are suppressed, and their FSH is appropriately lowered. Again, goserelin monthly versus quarterly, evidence of estradiol suppression. And you can see here the percentage of patients with E2 greater than threshold, and here there are some thresholds that were used with ovarian function suppression, where on an ultrasensitive assay, patients over time may take some time to get below assay, and a substantial proportion may stay above a 2.72 assay. It's not so clear, though, how relevant this is to their outcomes. We worry more when they're above 10 or certainly above 20, because that would indicate that they are not at a postmenopausal level. And you can see here just some changes over time with the use of ovarian function suppression medications, and how some patients can break through kind of seemingly randomly when they remain on ovarian function suppression medication. So, when we think about should we have ovaries removed, we don't tend to do it, particularly in someone where you might let their estrogen back someday, or certainly if they want to preserve fertility, but it does remove the uncertainty generally of does a person have to get a shot on time and will they break through, although the majority of people don't have their ovarian function suppression breakthrough. at our group, we've actually set up a monitoring schema for patients who are starting either monthly or every 3-month ovarian function suppression medication. And so that we can make sure that they are suppressed both clinically and biochemically. And then we have an algorithm for how we follow them. Should they be, suppressed or less than 10 on our standard measures of estradiol, then we just continue to monitor. If they're in kind of this 10 to 20 zone, we will, if they're high risk, we might switch them to tamoxifen off an aromatase inhibitor if that's what they were on. If they're lower risk, we may follow them a little bit longer. And certainly if they're high risk and their estradiol remains above 20, we'll generally either have them get their ovaries out or we'll switch them to tamoxifen until they're really suppressed, because it can take a little while for some patients. That's it.
I'm curious, when you do your monitoring, roughly how often you see that the patients are not suppressed fully.
So we are actually looking at those data now. So based on that algorithm, we have been following patients in a kind of real world setting here at the Dana-Farber, and we have over 400 patients that one of our senior fellows is looking into right now in terms of how frequently they break through with regard to clinically as well as biochemically. So we'll have those data. What I can tell you is anecdotally, it's infrequent that people do break through, but I get emails from all over the country from colleagues who are asking me, what do I do? She's on, I'm trying to decrease the frequency of her shots. I've got her on maximum dose. Should I give her a higher dose? Should I make it every 3 weeks? I've gone to monthly. Do I need to take this young person's ovaries out? And what I typically do in that setting is, obviously it's much easier for someone if they're done with their babies and they're going to, go into menopause soon anyway. Those people you say, just either take the ovaries out or ride it out and put them on tamoxifen. For a higher risk person where taking the ovaries out is really not an option because they may want to have a future child, or, they're only in their 20s and you might want to let their ovaries back after they get through, 5 to 10 years. For that person, I tend to use tamoxifen, and I've anecdotally, and use ovarian suppression with that, because then you're not as worried as if they break through, even if there is a small, benefit in terms of using exemestane. If it's not getting kind of the suppression you need from the ovarian suppression, especially if they're well into a premenopausal range, then you're not sure how much you're helping them with the ovarian function suppression. And obviously, this is something you kind of discuss with every patient and come up with what feels like the best fit for them based on their preferences, tolerance, and the risk of their cancer.
How do you, if they're on ovarian suppression and tamoxifen, how does that affect the estradiol level as well, the tamoxifen, as well as the FSH level?
Yeah, so the ovarian function suppression should lower the estradiol. The tamoxifen itself generally doesn't seem to affect the estradiol quite as much, but it can affect the FSH, and it can make the FSH look like it is lower than it actually is. It can suppress FSH in addition, which in patients who are not on ovarian suppression, it can be really confusing if you're trying to decide if they're going into menopause, because they can have low estradiol on tamoxifen, but have still a low premenopausal FSH, but there really could be postmenopausal. So in those patients, I'll often switch them and then follow their estradiol on the aromatase inhibitor and make sure they're staying in the postmenopausal range in the estradiol.
So I love this algorithm. This is just Dana-Farber, or is this a national algorithm
So
for
we
dosing?
made it up. We made it up, and we, to be honest with you, it was hard to follow. So not everybody followed it. We found that when we were looking into the data, but it made people a little more aware of checking estradiol on patients, especially when they were either high risk and or experiencing symptoms of concern. We know from the SOFT trial, they did the SOFT S trial, and we know in that trial that about 18% of women at some point in their early follow-up had breakthrough ovarian function despite being on ovarian function suppression in that group. Again, we don't know that it affected outcomes because we just don't have large enough data sets to look at that. But we're always looking to figure out why our youngest patients seem to do the worst in terms of their outcomes in ER-positive disease. And this may be one of the reasons. So if we could have better management of those who have breakthrough, maybe it can impact on the outcomes. That's the hypothesis.
Also, I noticed in the algorithm that for patients with higher estradiol levels, you have increasing the dose. It says Luprolide. Do you do the same thing with Zoladex?
Sure. We'd increase any dose if they have an option to increase the dose. And again, this is now working kind of a little bit from best judgment, not necessarily evidence-based. It's what does the prudent oncologist do, is what I like to call that. And we decided by consensus among our group to try it, and then now we're going to look at the outcomes and see if it worked.
Do you have any anecdotal feeling about whether it works or not?
My anecdote is that it's really hit or miss. It's not a sure thing, I can tell you that. And there are patients that I care for that, they don't want their ovaries out. They're on the highest dose they can get on their GnRH agonist. They're coming in monthly. And one lady, we switched to aromatase inhibitor because we just couldn't get her suppressed. We switched her to tamoxifen because we just couldn't get her suppressed on the aromatase inhibitor. And we were really worried. This went on several months, and she was reasonably a couple lymph nodes involved. And once we switched her to tamoxifen, her estradiol went below assay. So wow. We don't know whether it was the tamoxifen, whether it was happening over time from the OFS. We don't know. But we decided we would leave her on tamoxifen because she'd been above assay and looking premenopausal on ovarian function suppression and an AI for so long that we thought it was dangerous at that point. So we decided to switch her to TAM, and then she went below assay. So again,
I thought tamoxifen increases estradiol levels.
So I don't know that it increases any it does in premenopausal women. Yeah, when you're not suppressed, yes. Oh yeah. So in a regular person who's not on ovarian function suppression, it does for sure. But when you're on the ovarian function suppression, it shouldn't. But,
So last question, I've asked you this before, but I'm just going to ask it again, which is we hear about pure antagonists in prostate cancer. There's even an oral one, relugolix, and there's also an injectable one, derigelix. The last time I asked you, they hadn't been looked at in breast, I think, and I was curious why they haven't, but is that still the case? It seems like it'd be nice to have an oral agent.
I completely agree, and I really hope that we're able to study these agents for our breast cancer patients in the future.